with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening. Welcome to Dialogue with a Doctor. We're here this evening with my co-host Jim York, but primarily we're interviewing tonight Dr. Mei Fu. She's a radiation oncologist with 21st Century Oncology. And we're going to talk about breast cancer tonight.
Yes, Breast Cancer Awareness Month,
and
October.
Dr. Fu, before we go into that, could you just give us a little background about how long you've been in Naples, where your offices are, where you were brought up, and where you went to medical school?
Yep. I actually grew up in the Midwest in Michigan and went to medical school in North Carolina, and then actually went up to Minnesota at Mayo Clinic and did actually internal medicine first, and then went into radiation therapy, and then went down to Mayo Clinic Jacksonville and worked for about 7 years, and then came across the state and started working with 21st Century. So.
And where's your office located?
We have several offices, I think 5 offices in Bonita, and then across from NCH Hospital in the Commons, and then also we're opening up an office kind of off of Collier Boulevard next to Physicians Regional down there, and another office off of Mockley Road North. So just so it's convenient for patients. We basically go to all the offices so patients don't have to drive, so it's convenient for them.
I saw a building going up across from the hospital on 951.
Yeah.
Is that your building?
Yeah.
And when will you be in that building? You know?
Hopefully the next month. I know we had one open and then we closed it, but I think especially people who live out there in Marco, it's much more convenient for people.
Well, where would you like to start on breast cancer tonight?
Well, let's maybe start on radiation.
Yeah.
Where, you know, a lot of people really don't understand. They think of radiation as a certain way, and maybe you could just discuss it's not really what the perceived in the public it is today.
Yep, and I know like we had talked before, radiation is real scary for most people. And because you can't see it, you don't really understand how it works. And we should first say, you know, for cancers in general, we were talking about the 3 different treatments like surgery, radiation, systemic treatment like chemotherapy. Surgery and radiation are both more local treatments, meaning the effects and side effects are related to where we're treating, just like surgery. So, and the treatments really are high energy photons. The person does not feel anything or see anything during the treatment. I usually tell people, you know, they're usually in and out maybe 15-20 minutes. They're laying on the x-ray table, and they might hear the machine come on and off, and really don't really feel anything. It's like a long chest x-ray. The radiation works by affecting the DNA of cancer cells. And so the treatments are usually several treatments. It's not just usually one treatment. And that allows for what we say normal tissues to repair the effects of the radiation on the DNA or the reproductive part of the cell, because cancer cells are defective in their ability to repair the damage. And I mean, during the minute or so of radiation, it could kill off a cancer cell, but the effects will last longer. So if that cancer cell tries to grow and divide later, the DNA has been injured, so it could die off at that time, kind of reproductive cell death. So, you know, the side effects are related to where we're treating, what part of the body we're treating, but techniques have gotten so much more improved that most people really have little side effects. I mean, there's some that we really don't understand as well, like fatigue, but sometimes people, when we're treating the breast, might worry about hair loss or sore mouth or nausea, but really when we're treating the breast, the only couple of things that women might feel could be fatigue, but that varies a lot from person to person, and maybe some skin reaction, a little redness of the breast, but that's also kind of real variable from person to person.
So you said high energy photons. It reminded me of Star Trek. What do you mean by high energy photons?
They're kind of high energy X-rays or like radio waves. You don't really see it, but it goes through the tissues and affects the whatever tissues in the tract of the beam. But the radiation machine has multiple ways of shaping that radiation beam so that we can limit where we're treating, if it's really next to a critical structure. In the heart, or in the breast, we're probably talking about on the left side, the heart and lung. And on the right side is mostly just the lung. And there's some big jaws in the head of the machine that will bring the beam, narrow the beam. And it used to be that we used to have these big lead blocks that were custom made for each patient, that either just let the radiation come through or would stop it. Now we have these little, what we call multi-leaf collimators, which are little pieces of lead that move during the treatment, and it allows us to even kind of curve our radiation beam like around like the chest wall to minimize the dose to the heart and lungs, or prostate, minimize the dose to the bladder and the rectum. And that's where the side effects get improved, because we can aim better and...
So you can actually bend your beam around,
say, the breast sits right against the chest wall along the ribs. Mm-hmm. And so we can now, it used to be, we just went straight through all of that tissue. We would kind of come in at angles like this. And now with intensity modulated radiation, mm-hmm. because of computer planning, because of all of this, we can curve our radiation beam to kind of customize it to treat the breast and minimize any other radiation. Same thing about prostate cancer. We can really increase our doses because we can minimize the dose to critical structures like the bladder and the prostate.
And how many people have breast cancer? Just bring some statistics out on that, and then maybe talk about, do you do radiation before you do surgery or after surgery, or who's a candidate for either or?
Yep, and breast cancer, probably 1 out of 8 women will develop breast cancer. So last year, I think there were maybe 230,000 cases of invasive breast cancer,
right.
almost 60,000 cases of non-invasive breast cancer. I know we think, and a lot of patients come in and ask, why is it becoming more prevalent? Why are we seeing more breast cancer? But actually, over the past 10 years, the incidence in the United States has actually decreased by about 2% a year, although that's mostly in women who are postmenopausal or more than age 50, and they're attributing that to maybe some of the data from the Women's Health Initiative study talking about hormonal replacement therapy. So now that that's kind of data's been out and women haven't been put on the hormone replacement as much, that's why part of that has decreased, they think, the prevalence. I mean, on the other hand, there's probably like over 2 million survivors with breast cancer also. So
the prevalence, I mean, that leads at least me to think about and if there really is prevention, then the prevalence will drop. So I'm wondering if some of that is due to lifestyle at all. There's no way to measure, I suppose, that.
No, I mean, excellent question. I mean, that's where I think we all would like to go, is changing from treating an existing cancer to preventing the cancer. And I think the two aspects of prevention are early diagnosis with screening, and then maybe reduced risk, meaning lifestyle changes. With lifestyle changes, there's some things that are associated with an increased risk of breast cancer that we probably don't really have a lot of impact that we could change. It mostly has to do with the exposure of a woman's body to estrogen. So if she has an early menarche or having periods early and late menopause, or if she has not had children, those are all associated with probably a longer exposure to estrogen in their body, so it increases the risk of breast cancer. But some of the other things that we might have more control over, now there's been association with weight, especially in postmenopausal women, and by weight meaning also diet and alcohol consumption. There actually are some studies that say the more alcohol a woman drinks, the higher her risk of developing breast cancer. So, a woman who drinks an alcoholic beverage once a day might have a 10% increased chance of breast cancer. The other thing that people are looking at now are vitamin D levels. Even though we live in Florida, if you have kind of a deficiency in vitamin D levels, it can be associated with an increased risk of breast cancer, colon cancer. And again, with weight, exercise is also important. So those are things that are difficult to change in our kind of lifestyle, but probably have the most impact that we can do to reduce our risk.
How about different nationalities?
And this is interesting because, probably Caucasian women probably have a higher risk than probably African American women or Asian women or Hispanic women. Although African American women, it seems to be a little bit more aggressive and a little bit more prevalent in younger African American women. When we look at women who are born elsewhere, say in Japan or China, Asian women have a lower risk. But if they move from Japan or China and move to the United States, their risk of breast cancer actually rises to the natural population. So
it's not purely genetic, it has to do with the environment that they're in.
Yeah.
And I'm wondering what that is.
Yeah, and I don't know. I guess if I knew, if I knew, I'd probably be getting a Nobel Prize. But I wonder if part of it has to do with our lifestyle, our weight, exercise, diet. Yeah. I guess the other part of the prevention is just early detection, and I know there's a lot of controversy about kind of when should a woman start having mammograms. American Cancer Society and the American College of Radiology have maintained, at age 40 every year without really having any endpoint of age. But the United States Prevention Task Force came out with a change, and they recommended starting at age 50, maybe every couple of years, with maybe stopping at age 75, 74. I guess my personal recommendations, I think, would be to have it done every year, and that's partly just because of what I see and what I treat. But
well, it's also what I see, and I think most physicians come to that conclusion. I assume there are other reasons why the U.S. Preventative Task Force came to their conclusion, because they're thinking about economics and many things. But I see patients who are afraid to get a mammogram because they're thinking that it's going to cause them to get cancer. And I thought that belief was well buried years ago, but can you talk about that?
Yeah, we hear that also. And I have friends in the medical field that have never had a mammogram because of partly that. But the amount of radiation, delivered with a mammogram is so low that really the benefits outweigh those risks. They are looking at new types of screening examinations. It's still would involve radiation exposure, but may reduce the kind of incidence of callback mammograms. When a woman has a screening mammogram, they might see something, and then she has to go back for a diagnostic mammogram. That's a tomosynthesis is a 3D mammogram. I mean, this is all kind of in the horizon. It's not something that's used right now, but and then we're also very lucky to have other kind of experts in other modalities like breast MRI. Most of the facilities have gone to digital mammogram and computer-aided diagnosis, CAD, that can also help detect small lesions. We also have this breast-specific gamma imaging equipment. We're just very fortunate in Naples. Most probably communities this size wouldn't support all of this very specific treatments and evaluations. So.
Well, we're going to take a short break, and then we'll come back and talk more about some of the details of what you do and educate our viewers a little more. We'll be back in just a moment.
Thank you.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together, was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects, and that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It's just the right dose of radiation to the cancerous areas. Fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
Welcome back to Dialogue with the Doctor. We're here this evening with Dr. May Fu. She's a radiation oncologist with 21st Century Oncology. And we're talking about breast cancer, breast therapies, prevention, and now we're going to talk about what you do for a living, radiation therapy. And
radiation therapy for breast cancer. And we talked a little bit about how well women tolerate radiation to the breast. You know, the usual treatment and standard of care would be a lumpectomy, meaning surgery removes what we could see or feel. Radiation would be to treat anything microscopic that could be left in the breast. And I think there's been probably more than 15 studies, at least nationally and internationally, really establishing that as a standard of care treatment. The other treatment would be a mastectomy. There's rare times that we would give radiation after a mastectomy, only if the tumor is very large or there's multiple lymph nodes involved. We'll talk pretty much about the more breast conservation therapy with a lumpectomy and radiation. Like I said, the standard of care would be radiation to the whole breast over about 6 weeks, 6.5 weeks, daily Monday through Friday. The new things that people are looking at are what we call accelerated whole breast irradiation, meaning we know we have to get a certain dose of radiation in radiobiologically to get rid of those microscopic cells. And there's different fractionation schedules that we could use to deliver that radiobiologic dose. So the standard would be over the 6.5 weeks. What people are looking at now is raising the dose a little bit, and then compressing the treatment course to about maybe 3.5 weeks instead of 6 weeks. And there's been a meta-analysis that shows actually very good early results, like 5-year results with that. And we, you know, the main thing is, patients tolerate this well also, but the main thing is the time for women who have transportation difficulties or unable to, you know, go through treatments over 6 weeks. The other thing that people have been doing actually for a while is partial breast irradiation. And there's different ways of delivering that, meaning that the radiation is delivered only to a portion of the breast, that portion of the breast that where the lumpectomy was performed.
Who's a candidate for that versus the whole breast?
The whole breast.
Right.
Yeah, and this is where, again, I always make sure women realize that that it's not the standard of care yet.
Right.
But the women who would be candidates and that have had good results are women who have small tumors, at least less than 3 centimeters or smaller. They really shouldn't have any lymph nodes involved. They should have clear margins, and it's primarily for infiltrating or invasive ductal cancer. Lobular cancer, we usually try not to use it for because lobular cancer can be a little bit more disseminated in the breast, so we feel a little bit more comfortable treating the whole breast. And the partial breast irradiation, there's different ways of delivering it. We've done it and still do here in our practice using a balloon called a mammocyte, where the surgery is performed and then the balloon is placed in that cavity, and then a radioactive seed is placed into that balloon. And this is all, the radiation portion is all as an outpatient. So the woman doesn't feel anything as we put the radiation seed in because the balloon is already in the cavity.
So you leave a balloon in the breast with a catheter and you go down the catheter and put the seed in.
And the treatments would be delivered twice a day for 5 days. And then everything comes out. And it comes out in the office, so it's not another surgical procedure.
So it's an outpatient.
Yeah.
An outpatient.
Yeah, and there is another way that people have been looking at, actually been doing it in Europe for quite a while, but are now in studies called intraoperative radiation, where right at the time of surgery, 1 dose of radiation is delivered using an applicator, kind of like a balloon, but a metal applicator that's placed in the cavity and then hooked up to the radiation machine and delivers 1 dose of radiation right to the lumpectomy cavity.
But we're not doing that here yet?
We're not doing that yet here. It's currently under kind of clinical trial. Mm-hmm. I think they are doing, looking at that at Moffitt Cancer Center. The other thing that people are looking at with breast radiation is almost kind of like the prostate with this with these markers,
right,
to compensate for movement of the prostate gland. The same thing, actually even more so with breast, because when a woman's breathing, the breast moves. Is to use a similar marker, this calypso marker, that will also track the movement of the breast, and kind of use the radiation only when the breast is in the appropriate position for treatment. So,
how long after surgery do you have radiation?
Usually we talk about 3 or 4 weeks, basically to let the body heal up, because the radiation could slow the healing process. There is also some controversy about if systemic treatment is recommended by, say, a medical oncologist, meaning chemotherapy. There's not been really any data saying that sequencing chemo first and radiation afterwards or vice versa is better, but in most of the clinical studies, the chemotherapy is given first and then radiation. So, you know, if chemotherapy is in the picture, that's usually what we do. Is the woman usually gets chemo first and then the radiation. But like I said, the radiation just really tolerate it so well. There was another way that sometimes we still do sometimes, is a sandwich technique, meaning the woman has surgery, she gets half of the chemotherapy, and then she comes and gets radiation, and then the remainder of the chemotherapy. But I think in some ways that's tough on women, because sometimes it's hard to go back to chemotherapy when they've had the break, because of side effects and and they heal up during the radiation.
So when a woman gets a mammogram, I'm sure, most women are familiar with the breast being manipulated and squeezed between plates. But for radiation therapy, you don't do that. You're just, the patient's just laying there. Can you describe that for us?
Yeah. For radiation, the woman just lays on a X-ray table, and then the machine will rotate around her. She'll have some tattoos on, and there's laser lights in the room that line her up, and then the radiation is just delivered externally without any need for manipulating the breast.
How long?
The treatment is usually itself just a couple minutes.
Couple minutes. You don't feel anything and just walk away.
Yep. It usually takes them longer to come for their treatment and get set up and lined up than it is for the actual radiation. Yeah.
And what kind of side effects occur after radiation or during radiation?
The only couple of things could be tiredness, and then maybe some skin redness of the breast. But I said that varies a lot. We usually, the only two things we say is don't put anything on the skin surface right before treatment, because that could accentuate a reaction. And then aluminum-containing deodorant on that one side.
Go on.
Oh, I was going to say different radiation doses for different type tumors? Or is it similar or the same?
It's similar in the most common kinds of breast cancer, DCIS, non-invasive or invasive lobular or invasive ductal. We just know we have to get that certain dose of radiation in for kind of microscopic disease.
Survival rate, I mean, I know it's probably different for different breast cancers, stages of it, but in general what it is to tell our viewers.
Yeah.
So most people are worried when they get any kind of cancer they're not going to live, but technology has come a long ways today, right?
Yeah, and like I said, I think the survival is improving, but the biggest things are getting the mammogram, getting it detected early. So
prevention rather than treatment.
Yeah, and detecting early.
That's right.
Well, we'd like to thank you for coming. We've learned quite a bit about your treatment and your office, and we'd like to have you back again. Tell us about some other treatments.
Thank you for inviting me.
Thank you.
Thank you.